Welcome back. My next guest is Dr. Gary Earle, a cardiothoracic surgeon, and Jeannie Thompson, who's a lung cancer nurse navigator. Dr. Earle, you operate on lung cancers, but before we talk about operations, we talked about the symptoms and who might get it. A lot of times I end up seeing a patient and they get a chest x-ray for something else and they've got a spot on their lung. Tell me a little bit about the workup. What happens next? You do a CAT scan, MRI, a PET scan? What happens?
Jeff, that's a good question. I'd like to expound a little bit on what Dr. Ari said in the previous segment. Lung cancer is the leading cause of death from cancer in this country in both men and women. And that includes, if you include colon, breast, and uterine cancer, it far exceeds the death from cancers in this country. So it is a very, very lethal problem. And it's usually picked up by either inadvertently from a cough, or if someone's had a chest x-ray for some other reason perhaps. But if it shows a spot, especially in this state, we're going to think first of lung cancer. And we want to rule that out. So the next step probably would be a bronchoscopy. And what that is you do a video bronchoscopy through the nose or the mouth, and you look into the lung, into the bronchial tubes, and see if you can see the mass or the spot. Most of the time, however, you can't. And that leads you to the next step, and that's to get a CAT scan of the lung and localize the position of this mass or spot, and then either do a needle biopsy, usually radiology does that, with CAT scan localization, we call that, to actually get a needle into the spot and get cells and tissue that the pathologist can look at. You would like to find out if it is a cancer before you do the next step, which would be a thoracotomy.
Now, that's a type of surgery. But before we even get to there, there's other, especially in Kentucky with histoplasmosis, it's not always lung cancer. I mean, there's other nodules you see, infections. What would be some other things other than cancer that would give you a abnormal chest x-ray?
In this state, especially in this area of the country, histoplasmosis would be one of the main things that you think of for a differential diagnosis. Another thing could be anthrosilicosis, which is coal miner's lung, so to speak, which we have a lot of that, of course, in this country, in this state, in the eastern part of the state especially. So that's why you would like to try to get a tissue diagnosis from either the bronchoscopy, which sometimes can see the mass and you can get a biopsy that way, or through a needle biopsy by the radiologist. There's a new procedure open now, especially at Central Baptist, called Navigational Bronchoscopy, where they can go to the periphery of the lung with CAT scan localization and using the CAT scan to actually direct the bronchoscope. The pulmonologist does that test, and sometimes you can get to the very periphery of these lungs and get these spot diagnosed with a needle biopsy. So it's called navigational bronchoscopy. That's one of our new techniques and diagnostic tools that we have at Central Baptist to try to find out the etiology of these spots.
Now you talk about navigational bronchoscopy. You're a nurse navigator, so you deal with helping the patients get through this. And actually, before they get to the process where they have lung cancer, you may actually help them in terms of screening also.
That's correct. I meet patients at different areas of the continuum. Most recently, with Dr. Ari had mentioned the lung screening scan. We started our program at Baptist around a year ago, and there's certain things that we would recommend: a patient's age, a patient's pack year history, or how many cigarettes they'd smoked over the certain amount of years. And then I can help direct that. I can help a patient understand if they're appropriate for this scan, or and then help them work with their physician on getting the test ordered. I also meet with patients at different areas of the continuum when they're diagnosed with lung cancer.
All right, now so if you got a diagnosis, Dr. Earle, and you're going to operate on them, tell me, I mean, do you open the lung up? Is there microscopic surgery? You take just a lump out? Explain some of the options to us.
Jeff, before I go into the actual techniques, I think we also should state that at least 2/3 of our patients that come to the doctor with a spot on their lung and then are diagnosed with having lung cancer, 2/3 of those patients, 2/3 now, will not be operable. And therefore, you've got to stage the cancer before you operate. And I don't want to get into the specifics of that to state it depends on the size of the tumor, whether lymph nodes are involved in the tumor, and whether the tumor is spread to other organs outside the lung. So you have stage 1 through 4. Usually stage 1 and 2, which are usually smaller lesions, lymph nodes aren't involved, then you can operate. But in stage 3 and 4, you either ask the oncologist to try to do some oncology chemotherapy to try to shrink the tumor down before you operate. If it's already spread outside the lung, though, it's not operable. So 2/3 of our patients, when they're diagnosed with having lung cancer, will not be operable.
Now, that's a good reason for early detection,
correct,
prevention, and get it quick.
That's correct.
So if you do have to operate,
there are some new cutting-edge things in technology that we're doing now. We used to do a standard thoracotomy, where we'd make an incision in the back about 6 to 8 inches, spread the ribs, go in with our hands, and we still do that a lot, and take out the lung cancer with equipment and instruments, with hands actually on the lung. And that's been the time-honored surgery for the last 30 or 40 years. Now there are 2 other options called minimally invasive type surgery. One is called VATS, or video thoracoscopy, and there you make small incisions in the chest wall. You place certain ports in there and cameras that can see the lung, and then you operate through long instruments, rarely touching the lung, and then you can take out either the spot, a part of the lung, or the entire lung with that type of procedure. A newer procedure that we're now doing at Baptist, not every case, but on certain selected cases, it's called robotic thoracotomy. And the robotic surgery, where actually you place the ports inside the same way you do the video camera through small incisions, but the hands in there are controlled by the computer console that the surgeon is, and he is not actually touching the patient. He may be 6 to 8 feet away from the patient, and he's directing the arms of the camera and the video robot to actually take the lung out, either the lung or the spot. And we're starting to do that. The benefit from that is usually you get home sooner, usually less pain because you're not spreading the ribs, you're not creating that kind of painful situation. So usually 1 or 2 days less time in the hospital from either video thoracoscopy or robotic thoracoscopy.
So
thoracotomy.
I mean, those are an easier way to recover and get better quicker if you're a candidate for that.
If you're a candidate, that's correct.
But not everybody is a candidate for that, and you still require the standard old
that's correct.
operation. Now, after they've been operated on, do you help them after the operation too?
I help them whenever. So yeah, I'm available to help them after surgery, to talk about discharge instructions, what to expect when they go home, to answer questions that come up with survivorship down the road. So I'm always, I always tell them I'll be your nurse for life, and I hope that's a long time.
Well, now also, is it November is Lung Cancer Awareness
It is.
Month?
November is Lung Cancer Awareness Month, and I am. We talk about lung cancer being a terrible disease, and it is, but I want to support those patients that have it, their families. And so we have a couple events going on Tuesday, November the 12th at 6:30. We're going to have a Shine a Light on Lung Cancer Vigil, and there we're just honoring patients, getting together, hearing some survivor stories. It's going to be a nice time. And then on Saturday morning, November the 16th, there is a lung cancer walk at Commonwealth Stadium. So if people have questions, they can certainly call me.
And you'll help them along the way,
yes,
no matter what.
No matter what.
Well, Dr. Earle, if you had to tell somebody, you know, because it's so important to make a diagnosis early, is smoking still in your mind too the biggest thing that you tell them not to do?
No question about it, Jeff. It is the #1 cause of lung cancer in this country.
Now, if somebody has trouble talking, trouble breathing, coughing up blood, they should see their primary care doctor, their oncologist, their CT surgeon. They need to start with a regular doctor?
Absolutely. I think that's the first place to go. And from that, usually a chest x-ray will be done. And most of the time, when we see the patient, they already have the chest x-ray and the CAT scan. And they're really sent to us to then make a diagnosis of that spot on the lung.
And Jeannie, you can help them navigate it, whether it be their oncologist, their radiation doctor, their CT surgeon. You can help them through the whole process. And you can also help them emotionally.
That's correct. Our CT surgeons, for instance, go out into the community and to clinics all over the state, and so I'm not able to meet with people immediately one-on-one, but I can be available by phone and can spend an hour with you on the phone explaining things to you, comforting you, helping you know what to expect down the road.
Well, it's great information. We appreciate you coming in. Thank you for all your help. We'll be right back.